Assalamu alaikum wa rahmatullahi wa barakatuh. Again, this is Dr. Nuha. I'm a specialist of Singaini. Today, our lecture is about management of urinary tract infection in a pregnancy. Outline will include introduction, classification, definitions, risk factor, complications, management, diagnosis, investigations, and treatment of urinary tract infection in a pregnancy. So, urinary tract infection means infection involved the urinary tract. The spectrum, either asymptomatic bacteriuria, in which the patient has no symptom at all, but when you order for her urine protein investigation, you will find that there are bacteriuria, to severe pyelonephritis. It is risk more in female than in male, around 14 in female to 1 in male. The lifetime risk of 20%. Most common medical complication in a pregnancy. Asymptomatic bacteriuria, which will we use AP as asymptomatic bacteriuria, is around 2 to 5%. Asymptomatic bacteriuria, if untreated, 40% become symptomatic. 30% will be acute pyelonephritis. History of urinary tract infection, it will increase 10-fold cystitis and acute pyelonephritis. Overall, UTI, urinary tract infection, 5%, pyelonephritis, 2%. So the classification, as everyone knows, either include lower urinary tract infection, which include cystitis, urethritis, and other urinary tract infection, which include pyelonephritis. Or there will be uncomplicated or complicated. Complicated means there's underlying structural or functional abnormalities. Again, the classifications of urinary tract infection in a pregnancy, either asymptomatic bacteriuria, which is persist colonization of urinary tract by significant number of bacteria in women without urinary symptom. Acute cystitis, distinguished from asymptomatic bacteriuria by presence of symptoms such as dysuria, urgency, frequency, nocturia, hematuria, and suprapubic discomfort in afebrile women, with no evidence of systemic illnesses. While the pyelonephritis, there will be significant bacteriuria in addition to systemic illnesses like lung or renal angle pain, pyrexia, rigor, nausea, and vomiting. Urinary tract infection during a pregnancy is very common and associated with significant maternal and perinatal morbidity and mortality. It can be asymptomatic, as we mentioned before. So it is very important to do screening for all women by urine culture should be performed in early pregnancy, despite the cost. Treatment should be guided by urine culture and sensitivity reports. Antibiotic treatment should continue for 7 days, as shorter courses are not as effective during a pregnancy. So what are bacteriuria? Is a small number of bacteria, 10,000 colony forming units per milliliter. Significant bacteriuria is 100,000 colony forming units or 100 colony forming unit in catheterized specimen. Asymptomatic bacteriuria, same organism, 100,000 CBU per milliliter in 2 consecutive voided specimen, virulence related. Complicated UTI consists of 3 to 10%. It's catheter related. Recurrent UTI means equal or more than 3 times in 1 year or 2 in 6 months. And it's happening more in older women. Relapse, recurrent with the same organism, reinfection, recurrent by second isolate after normal intervening culture. So the most important part of this slide is that you know that what's mean recurrent UTI is more or equal 3 time of infection in 1 year or 2 in 6 months. So why it's happened more in a pregnancy? UTI increase in pregnancy because there is dilatation of the pelvic system more on the right side. Physiological hydronephrosis, in which there is increase in the pelvic calyceal system up to 2 centimeters. There is increased renal plasma flow more than 80% in second trimester, 50% in third trimester. Glomerular filtration rate increase, creatinine clearance rise to 50%. However, glomerular filtration rate estimation is not recommended in pregnancy. Microscopic hematuria, if a scan normal, no further investigation. Sometimes we do urine routine for pregnant women and we find there's microscopic hematuria, the red blood cell is increased. So if a scan is normal, no further investigation need to be done. Edema, 80% will be increased near term. Proteinuria, upper limit of normal, 300 milligram per 24 hour. PCR, 30 milligram per millimole. So what are the key recommendations? Screening for asymptomatic bacteriuria should be performed ideally at 12 to 16 week gestation on all women. Imaging of renal tract may be needed if there is suspected pyelonephritis or there is no response to treatment. We will not prescribe trimethoprim for pregnant women with established folate deficiency or women taking folate antagonist. Take single sample of urine culture before empiric treatment is started. Women with symptomatic bacteriuria with systemic sign of infection should be admitted for intravenous antibiotic, pending the result of blood culture and urine culture. So all women should do screening for UTI by sending urine routine and urine culture at 12 to 16 weeks. And if there is no response to treatment or there is systemic sign and symptom, we will prefer to do imaging for renal tract. Methoprim is better to avoid in pregnant who have folate deficiency, for example, women who are on anti-epileptic medication. And always, if you find that she has symptom and urine routine show white PC more than 20, you should start treatment before waiting urine culture. However, if there is systemic sign of infection, it's better to be admitted for intravenous antibiotic. When choosing antimicrobial, it's important to consider issue of teratogenicity and absorption. In cases where clinical improvement failed, occur within 24 hours of investigation treatment, or when there are additional comorbidity, additional senior medical or microbiology advice should be sought. Repeat urine culture should be sent a week after antimicrobial treatment is finished to ensure that the bacteria has cleared. Nitrofurantoin can be used for prophylaxis, but should be avoided near term on when delivery is imminent because of risk of neonatal hemolysis. So the side effect of urinary tract infection, as you know, on the baby, there will be low birth weight, there will be prematurity, there will be development and delay mental retardation, perinatal mortality will be increased. Again, there will be increased preterm labor for the pregnant women, less than 37 weeks. There will be increased risk of hypertension. There will be risk of anemia and polioamnionitis. So the effect of urinary tract infection on the fetus and effect of urinary tract infection on the mother. The most common pathogenesis is E. coli, 80%. In immunocompromised, sometimes the viral play role in UTI. However, the most common here is E. coli. We must focus if the pregnant women has urinary tract infection and you send for urine culture, and you found that there are group B streptococcal infection, group B streptococcal infection means GBS, please treat her at that time and write in the green part that she has group B streptococcal GBS in urine because she should receive intrapartum prophylactic therapy. So again, what are the medications that can I use for urinary tract infection? Either nitrofurantoin, but we say better to avoid it in last trimester because lead to hemolysis of the baby, and also avoid it in G6PD. However, this is not available in primary health care. So we can use amoxicillin, which is 500 milligram TID for 7 days. And again, we can use augmentin, co-amoxiclav, 625 milligram TID for 5 to 7 days. Ciproxime, which are preferred at a private clinic, they will use 500 BID for 7 days. Civalexin, 500 BID or TID for 7 days. So the medication available in primary health care that can be used for management for urinary tract infection in pregnant women, either amoxicillin 500 TID 7 day or augmentin 625 TID for 5 to 7 day, ciproxime BID for 7 day, civalexin 500 PD or TID for 7 day. So as you found that here, the treatment is for 7 days, not 5 days. What about pyelonephritis? As we mentioned before, pyelonephritis should be treated in hospital because need IV antibiotic. They can give either ceftriaxone, 1 to 2 gram OD IV until the patient is stable, 48 hours. Then you change to cephalexin 500 QID, 14 days. Or they can give clindamycin or ciprofloxacin according to the medication available in secondary healthcare. So again, what are the most common complaint in pregnancy is urinary tract infection. Asymptomatic should be bacteriuria should be treated. Acute pyelonephritis should be treated in hospital with IV antibiotic. Regular midstream urine to exclude reinfection. Amoxicillin and cephalosporin for treatment and the prevention of UTI. If pyrexia is preferred in this way or suspected pyelonephritis, we must send for midstream urine and the blood culture, full blood count, renal function test, lactate, and renal ultrasound, because here she has like systemic infection. And always we should encourage behavior and personal hygiene measures like increased fluid intake, because most of the women, they are not drinking water in proper way, and advice for double voiding, voiding after sex, and cleaning front to back. And these are the references that I use for this lecture. Thank you very much.